Hey everyone, and welcome to this explainer on managing stress ulcers in neurocritical care. You know, when you're managing critically ill patients, you quickly realize one undeniable truth. What happens in the brain rarely stays in the brain. Today, we're diving deep into the source material to unpack the specific, highly dangerous systemic complications that arise from central nervous system pathology. We're going to examine every crucial detail, because mastering these clinical nuances isn't just academic, it's absolutely vital for patient survival. So let's dive right in.
Okay, here's our roadmap for today. We're going to start by looking at the threat of stress ulcers, cover prophylaxis strategies, and confront the pneumonia complication. After that, we'll review our pharmacological toolkit, which includes H2 antagonists, proton pump inhibitors, and finally, sucralfate.
Section 1, the threat of stress ulcers. Let's get into it.
To really grasp what we're dealing with here, we need to talk about Cushing's ulcers. These are specific stress ulcers that have an exceptionally high risk of developing in critically ill patients who are suffering from CNS pathology. And here's the statistic that should instantly put you on high alert. 17% of these stress ulcers produce a clinically significant hemorrhage. That's nearly 1 in 5 patients. We're talking about a massive, potentially life-threatening complication rate for someone who's already in critical condition. So you might be wondering who is most at risk. Let's break down this extensive list because it really matters. First, we have the direct CNS risk factors. This includes severe brain injury, specifically those with a Glasgow Coma Scale score of less than 9. It also covers brain tumors, intracerebral hemorrhage, SIADH, which completely disrupts normal water balance, central nervous system infections, ischemic stroke, and spinal cord injuries. But here's the kicker. The odds of a hemorrhage increase significantly when those brain issues coexist with extra CNS, or systemic, risk factors. What are those? Well, we're talking about long-term use of steroids for more than 3 weeks, severe burns covering more than 25% of the body surface area, hypotension, respiratory failure, coagulopathies, renal or hepatic failure, and sepsis. So if your patient comes in with a severe brain injury and then goes into respiratory failure, their ulcer risk just compounded exponentially. I want you to think of the gastric environment like a really delicate seesaw. On one side, you have your destructive factors, acid, pepsin, and bile. On the other side, balancing it out, are your protective factors, mucosal blood flow, the mucus bicarbonate layer, endothelial cell replenishment, and prostaglandins. In a healthy body, this seesaw is perfectly balanced. But when you introduce severe CNS pathology, especially injuries involving deep brain structures like the diencephalon or the brainstem, you get a critical reduction in vagal output. This sudden loss of vagal regulation totally tips the scale. It leads to a massive hypersecretion of gastric acid and pepsin, meaning the destructive factors simply overwhelm the protective ones. And timing is everything here. Day 0 is the moment the CNS injury actually occurs. But the true danger zone, the absolute peak in gastric acid and pepsin production, hits right at days 3 to 5 post-injury. That specific window is when your patient is most vulnerable to that 17% chance of a major clinical bleed. Moving on to Section 2, prophylaxis strategies and risks. When we're talking about prophylaxis, there is one crucial target metric you need to memorize, a pH greater than 4.5. The evidence is incredibly strong that reducing gastric acid directly reduces the incidence of GI bleeding from these stress ulcers. The physiologic why behind this is that elevating the gastric pH above 4.5 actively inactivates pepsin. Basically, if we neutralize the environment, we effectively disarm those destructive enzymes. Now, let's talk about steroids for a second, because a lot of neuro patients are on them. It's super common to think, oh, they're on steroids, let's start prophylaxis. But actually, routine prophylaxis, just because a patient is on steroids, is not warranted unless they meet some very specific criteria. You have to ask, do they have prior peptic ulcer disease? Are they taking NSAIDs at the same time, like ibuprofen? Do they have hepatic or renal failure? Are they malnourished? Or is their steroid therapy going to extend beyond 3 weeks? If they don't check one of these specific boxes, routine prophylaxis purely for steroid use isn't actually indicated. Section 3, the pneumonia complication. Okay, so here is the ultimate medical catch-22 when it comes to acid inhibition. On one hand, bringing the gastric pH above 4 beautifully reduces the risk of stress ulcers. It does its job. But on the other hand, the normally highly acidic stomach is sterile. Acid kills bugs. When you raise that pH to a neutral level, you literally strip away that sterile barrier, which permits bacterial colonization right there in the stomach. And the fallout from this? It massively increases the risk of pneumonia from aspiration. The data even suggests that mortality might go up as a direct result. So we are constantly walking a tightrope, potentially trading one lethal complication for another. Section 4, histamine 2 or H2 antagonists.
Let's start opening up our pharmacologic toolkit.
We are going to go through these meticulously because, honestly, the dosing details are exactly what make or break your management. Let's look at ranitidine first, commonly known as Zantac. For adults 65 and younger, the dose is 150 milligrams orally twice a day, or you can do 50 milligrams via an IV piggyback every 8 hours. But notice how age completely changes the game here. For patients over 65 with normal kidney function, you have to adjust that down to an IV dose every 12 hours. You could also run a continuous IV drip at 6.25 milligrams per hour. That provides a much more consistent pH, but there's some debate out there on whether that steady state increases bacterial concentration. Next up is famotidine, or Pepcid. The standard maintenance dose is 20 milligrams orally at bedtime. But if you're dealing with an active ulcer, you double that to 40 milligrams orally at bedtime. For IV administration, it's 20 milligrams every 12 hours. Finally, nizatidine, or Axid. This one is taken orally either 300 milligrams once a day or split up into 150 milligrams twice a day.
Section 5. Proton pump inhibitors.
These are the heavy hitters of gastric acid suppression. Let's unpack exactly how they work at the cellular level. PPIs reduce gastric acid by specifically targeting and inhibiting the very final step in acid secretion at the gastric parietal cells. They do this by blocking the hydrogen-potassium ATPase enzyme system, that is the literal acid pump on the surface of the cell. Because they shut down this final common pathway, they stop acid secretion completely, regardless of what's stimulating it. But this immense shutting down power comes with real long-term consequences. For one, full recovery of acid secretion once you stop the drug might take weeks. Furthermore, they are not meant for long-term treatment. Prolonged use causes elevated levels of gastrin, which has trophic effects that can actually lead to gastric carcinoid tumors.
Now, pay close attention to this next point, because there is a critical difference in how these specific drugs interact with the liver, and it's a huge clinical pearl. Omeprazole, or Prilosec, actively inhibits some of the hepatic cytochrome P450 enzymes. This is a big deal in neurocritical care because it reduces the body's ability to clear crucial medications like warfarin and phenytoin, and it actually decreases the effectiveness of prednisone. The standard dose for omeprazole is 20 to 40 milligrams orally every day. Contrast that with lansoprazole or Prevacid. Lansoprazole has been shown to have no effect on drugs metabolized by cytochrome P450. It safely leaves phenytoin, warfarin, and prednisone completely alone. Its dose is 15 to 30 milligrams orally every day, usually for a short-term treatment block of about 4 weeks. If your patient is on blood thinners or anti-seizure meds, remembering this distinction is absolutely vital.
To round out the PPIs, we have pantoprazole, or Protonex. This can be given orally at 40 milligrams daily for up to 8 weeks, or via IV at 40 milligrams daily for 7 to 10 days. As for side effects across this entire drug class, you're looking at about 1 to 5% of patients experiencing things like nausea, vomiting, headache, diarrhea, abdominal pain, or a rash.
And finally, Section 6, sucralfate, our alternative mucosal defense. Sucralfate is super interesting because it bypasses that whole acid reduction dilemma entirely. Instead of messing with pH, it acts almost like a liquid bandage by physically coating the ulcerated areas of the mucosa. But here is the magic phrase: it does not inhibit acid secretion. Because it leaves the stomach's natural acidic pH perfectly intact, that essential sterile barrier remains. This means using sucralfate might actually result in a lower incidence of pneumonia and mortality compared to the H2 blockers and PPIs we just discussed. Now, it's worth noting our source mentions there is currently insufficient data to definitively prove the net benefit compared to giving no treatment at all, but the mechanism makes a lot of sense. If you are going to use sucralfate, there are some very strict administrative rules you cannot skip. First, you need to know that it is minimally absorbed from the GI tract. It acts locally right where you put it. The specific dose is 1 gram, given orally 4 times a day. Crucially, it has to be given on an empty stomach. And lastly, you absolutely must not give antacids within a half hour of administering sucralfate. If you do, you'll completely disrupt its ability to bind to the mucosa, rendering it useless.
Which brings us to the very end of our deep dive, leaving us with this foundational, almost philosophical clinical question. In neurocritical care, you are always walking a tightrope. You have to look at the patient in front of you and decide, does the risk of a fatal GI bleed from a Cushing's ulcer truly outweigh the risk of ventilator-associated pneumonia caused by removing the stomach's sterile barrier? There is no simple one-size-fits-all answer, but with the comprehensive, detailed data we've just covered today, you are now much better equipped to make that calculation. Thanks for joining me on this explainer. Keep learning, and I'll see you next time.